Surgical septal myectomy can often restore the quality of life and also improve survival in patients with hypertrophic cardiomyopathy. However, the most favorable results have usually been obtained in patients with marked septal hypertrophy. What is the best approach for the sizable minority of HCM patients with significant LV outflow tract gradients but relatively mild septal hypertrophy? So we're talking about a paper that's in the October 13th issue of JACC, and it is transaortic chordal cutting is the topic, and I'm with Dr. Paolo Spirito, Galliera Hospital in Genoa, Italy. This is a great topic. We're talking mitral valve repair for obstructive hypertrophic cardiomyopathy and mild septal hypertrophy. Why is there a need for something a little bit different for these patients?
Because if the septum is septal thickness is mild, then it's not possible to perform an extended myectomy as it is usually performed in patients with obstructive hypertrophic cardiomyopathy and marked septal hypertrophy. And also in these patients, the mitral valve plays a major role in the obstruction because they have a mild septum, so unless they have a greatly abnormal mitral valve apparatus that moves anteriorly against the septum, they would not have obstruction. So if you focus all your operation on removing septal muscle, you can't remove muscle much because it's mild, the septal thickness, so you have to do something else. And for many years, nobody knew what exactly they had to do. So what usually happened all over the world, that many of these patients would undergo mitral valve replacement, which is not a good idea in young patients with obstructive hypertrophic cardiomyopathy for the obvious potential complications of mitral valve replacement. An alternative was mitral valve repair with insertion of a prosthetic ring, but also that is not ideal. And this problem has been debated, but a solution, definitive solution, had not been found. Now, we don't want to say that our is a definitive solution because the study is based on 39 patients, so it's a relatively small cohort. I must say that the study was completed in 2013, as always happened, so we had 2 more years of experience. The results are great. And I must say, I am a cardiologist. The person who does the operation and also has developed this type of intervention is Paolo Ferrazzi, who is the first author and is a surgeon. And I think he's the surgeon with the largest experience with surgical myectomy in Europe. He's a surgeon that has operated the highest number of patients with outflow obstruction, with HCM and outflow obstruction.
So talk about chordal cutting, just what's involved.
So you have to know the anatomy of the mitral valve. So there are primary and secondary chordae. The secondary chordae are attached to the ventricular surface of the valve. And they contribute to ventricular function, and while the primary chordae are attached to the edge of the leaflet and prevent mitral valve flail and regurgitation. So when the mitral valve apparatus is normal, everything works okay. What happens in these patients with hypertrophic cardiomyopathy is that the secondary chordae are often thickened and retracted. So it's difficult to describe like this, but because they are thickened and retracted, they pull the mitral valve apparatus against the septum and therefore generate an obstruction. And what we have seen in our experience is that if you cut a selected number of these secondary cord, the mitral valve goes back to its normal position in the inflow area of the ventricle. The mitral regurgitation disappears or goes, is reduced substantially, and without having to perform an extended myectomy. You have to do some myectomy. We would be curious, the surgeon would be curious to know what would happen in some of these patients if, with very thin septum, if he didn't do a myectomy. But, it's unethical to try.
Now, relief of symptoms is the goal behind surgery. In this case, are the patients finding relief?
Absolutely. Relief. Relief of symptoms is the target.
Right.
Relief of obstruction and relief of symptoms is the target of myectomy. And myectomy and also this operation. And these 39 patients.
You achieved it in all patients.
In this, absolutely. But myectomy in general, I must say, I would like, if I have a chance, to communicate this information. It's not well known. Myectomy is, for the surgeon, one of the most possibly the most gratifying surgical intervention, because within a few days, the patients feel their improvement.
Right.
They lose their functional limitation. There is no other, surgical intervention that for mitral, valve anomalies, not even aortic stenosis, that generally gives those changes. And these are young patients.
So how often will you see patients who might benefit from this procedure?
We see, this is one of the problems, that there are a lot of patients out there with this problem, but the cardiologists and doctors are not yet aware of the potentials of myectomy. We have been trying through the years, now for 20 years or more, but we are getting there. And because the number of myectomy operations has increased exponentially. And you should consider that hypertrophic cardiomyopathy is the familial genetic disease with highest, by far, the highest prevalence in general population. 1 in 500 people is the estimated prevalence. And the proportion of these patients, an important proportion, have obstruction. So the number of candidates would be much higher. And now, in fact, one of the problems that we are confronting now is the fact that the number of surgeons in the Western countries, particularly in Europe, but also in the United States, with experience with this operation is not large enough. In fact, we have been to Russia, Kazakhstan, where they are interested in this to try to learn, to teach. They are interested in extending this procedure to other countries. A lot of countries in Europe need more surgeons for myectomy.
The topic is a good one. It's transaortic chordal cutting, and it is a paper that you will read in the October 13th issue of JACC. And for CardioSource World News, I'm Executive Editor Rick McGuire.